Okay, another case study. This is a case study. I'm going to look at two different time points about 3 years apart from each other. This is when the patient started, had an implant, came in, but it was having trouble with his teeth. So this is a patient that has a history of cancer and had radiation treatment. And this is a very, very big important lesson. And I do see this more times than I would like not to, is that the medical field does not emphasize the importance of oral health care for a post-operative treatment or post-treatment of radiation treatment for cancer patients. What happens with radiation treatment in this particular case, the salivary flow, the saliva glands get knocked out and creates a very, very, very limited salivary flow. And what occurs then, if the patient, even if the patient has moderately good oral hygiene, brushing, cleaning, all that stuff, will be susceptible to severe decay. This is one of those cases. This is a retired senior, 70 years old plus. In this case, I think he might be late 60s here, and is recovering from the cancer, but is having a lot of trouble with his teeth, and has had some dentistry done with the general dentist. Is now kind of found me, but then has now realized the severity is kind of gone so far. Patient's on a fixed income, doesn't want to spend money. Financials always come into the picture. You always have to talk about financials with the patient, and you try to do the best you can. So this is one of those cases that was severe from the start, knew that it was going to be a big problem, but a big problem for him is financial, and also he didn't feel that at the time he was believing that he was going to live the next 3 years because he just had a bout of cancer. So his psychology played a big role in this case, and we'll look at it in actually that we just took a new current CT and we're trying to follow up with some of his work. The other aspect I want to mention about radiation treatment, which can be very problematic, if you look at my assessment sheet, I don't have in the medical dental history anything directly related to diabetes, which is a big problem for bone healing. But in this guy's case, he would probably be the red on the radiation treatment, because radiation treatment has so many variable effects. I don't know how else to judge it. I just like to put him as red, so it's always at the top of my awareness and the patient's awareness that when you're dealing with implants, even if this was done prior to his radiation treatment, still is in jeopardy of bone healing capacity. And so we're going very slow because implants are much more expensive than fillings or extractions or dentures or partial dentures, except that I don't know how much to trust his bone healing going on. So as we move along with extractions and bridge work, we're slowly looking at, does this patient heal? So he's been intermittent coming in, dealing with the limitation of his chewing capacity today. But this is the starting point of where he was. When we look at his case here, it's hard to tell, but if you could look here, you could see how what I call moth-eaten it actually is. There's a giant chunk of tooth structure right here that's taken out. There's big chunks out of here. This tooth is basically gone. There's not a lot there. Big pieces of tooth out over here. So there's nothing really much holding this tooth together here. This is pretty much gone. A lot of these have massive decay on root canal treated teeth. Now remember, root canal treated teeth don't have nerves anymore. They're devitalized, so the patient typically does not feel those. Usually those are the worst because they don't have the sensory feedback to get treatment or do something with. So I always say that root canal treated teeth, the next thing that those teeth are going to see is sunlight, meaning the only thing you can do in the end of situations like this when there's that root decay that's going on underneath the crowns is extraction. There's nothing else you could really do. So that's why bone preservation is so important, and to limit any sort of periodontal disease around those particular teeth or any molar teeth. Here, he has a very low-lying nerve. It goes very low and stops a little bit early. It kind of comes down this far. So he's a green on the nerve position on this patient here. Where he's a red is if we look at his arch here, he's a red on the constriction, becomes very narrow here on the upper, starts to narrow, and we're in the prime zone. And on the bottom, if I move this across, we see how it really constricts right here. Look at this. This is very difficult to work with, how it constricts down here on these curves. So one of our biggest problems, or anybody trying to restore teeth with implants, is you got to have bone. And that native structure that this patient has is not very good. He's also a big red on the facial bone. The facial bone, this being the cheek side of this tooth here, the lip side is what we call the facial bone, right across here, is extremely, extremely thin. So there's not really much bone there. And then he's got, very hard bone here. So when this tooth becomes extracted, if it's not grafted and supported, you're going to be losing bone. And it's going to fall back in this angle, and now you're left with really bone you can't work with. This is a very, very hard situation to do, and you're going to be losing a lot of possible implant sites, and especially if the patient doesn't have bone healing capacity, if the patient doesn't have that ability to kind of grow bone in this area, even if you put a graft, will limit their options for really anything, and all you're left with is the denture going over this area. And a tricky part to this patient here too, to add more to it, is he has these large tori, and tori are bony segments that had developed when had a lot of clenching events going on. So back in his earlier, younger days, probably from his 20s, 30s, 40s, he probably clenched a lot, put a lot of stress on his teeth. The bone in the mouth only knows to react one way, which is to grow outward. It's not like your arm. So if your arm has an origin and insertion, the bone stretches more like a bow and arrow and gets stronger from 2 points flexing. But in a tooth, it's more like a peg into a hole, and now it's stressing up here, and this area here where the bone that's supporting it only can grow outward. And that's what we see here with him. So on a lower denture, these areas are very protrusive, and unless you take them away surgically, which is another difficult task, it's very difficult to put any kind of denture piece over them, because you have a thin piece of tissue and that denture's smashing right on the gum tissue, and it's very painful for a patient. So that's a difficult scenario. If we now look a little bit more, let's say, at some of the other areas of concern, I think that would kind of be it. There's not much more that I would say that we haven't already talked about with him in terms of cases. So let's look at the future him today. So here's where he started. I'm not going to go through his case over the last 3 years, but he's only been in intermittently. He has not been in on a regular basis for fear of spending money on dentistry, which is more of a habit in that he's incurred over the years, because when he was younger, he didn't have dental problems, and would just kind of go when he felt like going, and eventually accumulated dentistry like this over time. But like I said, there wasn't enough coaching from maybe there was. He claims not, but that the medical staff, or at least the medical treatment, was not going to have an effect in this manner. So let's get the CT up in a second. Okay, here we are today, 3 years later from when we first were presented with this patient's case. You can see most of his teeth are wiped out. We've been able to kind of put interim bridge work in there. He's slowly adding implants as he is losing his teeth where he can. On the bottom, we have 2 implants that we just checked today. Those are still valid. These teeth have all rotted off. This is still holding on, but that's rotted away. This is loose here because there's a lot of decay around here. It's a very difficult thing, but our next step for the bottom is to get fittings for these 2 implants that he has on the bottom and take those out and at least snap in a denture for now. But we have to get implants here. Because he's a red on the facial bone, it becomes difficult in this particular area here across this site. So this is where it adds difficulty to his case. And it's right across here, and this is where we're going to have to graft bone here and hope that we can maintain it. It seems that this patient seems to have some healing capacity because those implants would not have healed if he had no healing capacity, so we know he has that. Some of the other sites that we've been able to preserve are looking okay, but the quality of his bone, if we look at the quality of the bone here, does not look very good overall. It's kind of, the characteristic is very splotchy. It's very steel wool looking, and the characteristics don't look quite as normal or homogeneous as I would like to see. So it always leaves a question there. He does need to get these root tips out. I've been asking him to do that, but he can't force anybody to do that. And we're left with now getting out little root tips and things like that when those should have been out a long time ago as the crowns are breaking off. But like I said, he doesn't like spending money, and he just has a habit of showing up whenever he wants to. Now he feels very compelled to actually do something, and that's when we started last year, put these 2 implants in to try it out. This was done years ago when we first started, when he had more teeth, in lieu of having to use this for more of a big denture piece. We're looking at, on the upper, utilizing bone in this area for an implant here. So we think now that he does have healing capacity, so we'll be taking, now he wants the roots out, and so on and so forth. So it's coming along, but I think his quality of life could have been more optimized had he worked on this case earlier on when we first saw him, being a little more proactive, figuring out which teeth to keep and try out different modes of testing or trying implants in this case in a couple sites to see and test how long it takes for these implants to heal in his jaw. I've had other radiation case patients that we would let it heal for 5 to 6 months, but what I've seen is that I don't believe they last a lifetime. I guess a lifetime's relative to somebody that has cancer, but I would say, I'm thinking of one particular patient, had a lot of oral cancer, had to fix their teeth so that they could chew and have anything to eat and masticate their food properly for nutrition reasons. And over about a 5-year period, the implants were successful. We probably did about 6 or 7. The bad part is that he went to Mexico first. Not that Mexico's bad or that the dentists are bad, but in this case, he lost a lot of good bone with infections that he finally gave up on going to Mexico with. And after a few years of grafting and trying to rebuild that bone, putting implants in, we were successful in getting his teeth back in a very, very high-functioning manner. But unfortunately, over, let's say, the past 3 or 4 years, I'm seeing recession come around those implants, and the bone is not keeping up with the demand of what is expected of it when you're chewing and eating and functioning in a normal manner. So he's probably got another 5 to 10 years on the implants, the way I could tell looking at the bone loss rate around them, or more, I guess. It all depends on how much and how hard he chews on them. And so he's in, I think he's in an okay spot for where he is health-wise and where his health is taking him. So he will have a quality life for hopefully, as long as he can. So I think he'll do pretty well. In this case here, I think it's going to be a little iffy. This implant is still good. The bone around it is not so good. But if we could use this one, we could use this one. Maybe I can get something over here. Maybe we can get something over here. If I can get something here, even better. Here, we're trying to get something in here. And then we have this, and this was where we have a trouble spot on the bottom. But we can at least secure something, get this out, give him something to chew. He really is just teetering on a few teeth here and a few teeth here. And those are not going to last more than another year to 2 years. And the bottom is probably more like 2 to 3 months. And so we're going to be acting on that in the next coming weeks to get him something in place. So I hope that was helpful. And keep looking at case studies. You'll always learn something new.